Good afternoon, class. Today we are going to discuss about the anatomy of the external ear. So I have split the lecture of anatomy of ear into three parts. Today we will study about the anatomy of external ear. In next lecture, we will study about the anatomy of middle ear, and at last we will study about the anatomy of the internal ear. So let's start with the anatomy of external ear. So before starting the lecture, there is a one important line that is said about the ear. Sounds are everywhere, and you have two cool parts on your body that let you hear them all. So, which part of our body let us to hear all the sound waves that is present in the environment? So, that are ears. So, ears help us to hear the sound waves that are present in the environment. Okay. So let's start the specific portion of the anatomy of the ear. So ear is basically divided into three parts: external ear, middle ear, and inner ear. And inner ear is situated inside the one bone. That bone is the temporal bone. So temporal bone has different parts, and specifically the inner ear is situated in the petrous part of the temporal bone. So this is the important point you should know for your competitive examination. This point can be asked in your license examination as well as in the Lok Sabha examination, as well as any entrance examination. This question might be asked in your future examination. So we will start with the anatomy of the external ear. So external ear extends from the outer part till the eardrum. Eardrum is also known as the tympanic membrane. So it starts from the outer part and ends at the level of the tympanic membrane. External ear consists of pinna, external auditory canal, which is also known as the external auditory meatus, and last part is the tympanic membrane. So starting with the first part of the external ear, the first part of the external ear is known as pinna or auricle. It is also known as auricle. In pinna, you should know the name of the different parts of the pinna. So there are different structures present in the pinna. From outside, we can see there is a small pinna bilaterally of the skull, but there are different parts, different structure in the pinna, which is medically important, and you should know the parts of that name of that parts. So here you can see the lobule in the lowermost part of the pinna. So this lobule is the very important part of the pinna, because ear piercing, earrings are worn by the female as well as male in the ear lobule. So similarly, there are different another parts in the pinna. You should know the name of that part. So there is a tragus, and opposite to this tragus, this is the antitragus. There is a big C-shaped ring outside the pinna. So this C-shaped ring is known as the helix, and opposite to this helix there is a anti-helix. And this curve that is formed by the helix is known as crura of the helix. This curve formed by the anti-helix is known as crura of the anti-helix. And in the helix there is a elevation in the helix rim of the helix, and this elevation is known as the Darwin's tubercle or auricular tubercle. Beneath this crura of the helix there is a depression, there is a cavity, and this cavity, this fossa is known as the scaphoid fossa. Similarly, just below the scaphoid fossa there is another depression, another groove, and that depression, that fossa is known as a triangular fossa. Beneath the triangular fossa there is another cavity, and this cavity is very important for the exam point of view, because this cavity is known as the Simba concha, and this is a landmark for the mastoid air cells. Mastoid air antrum is just beneath the this landmark, and we will study this thing in the next slide. Below this there is a concha, which is a triangular in shape. This large area that is situated in front of the external auditory meatus, this area is the concha, and concha leads into the external auditory meatus. And above the concha, in between the crura of helix and the tragus, there is an area that is known as incisura terminalis, and this is also one of the important part of the pinna, which is medically important. And why is this important? We will discuss in the next slide. So this is the theory portion related with the pinna. So pinna is made up of a single yellow elastic cartilage except at the lobule. So lobule doesn't consist of the elastic cartilage. Lobule is devoid of the cartilage. Beside the lobule, there is incisura terminalis, which is also devoid of the cartilage. So there are two places in the pinna where the cartilage is absent. One is ear lobule, and another part is the incisura terminalis, where there is no elastic cartilage. The cartilage of pinna is continuous with the cartilage of external auditory canal. So we will see this thing in the diagram, and diagram is kept in the next slide. The cartilage is covered with the skin, which is closely attached on the lateral surface. So this cartilage is covered with a skin, and skin is closely attached, tightly attached in the lateral part of this pinna, but it is loosely attached in the medial surface. Medial surface means where the pinna is attached with the skull. So at the site of the attachment with the skull, the skin is loosely attached with the cartilage, and this cartilage is avascular. This is very, very important point for exam. This cartilage is avascular, and how does this cartilage gets its nutrition? This cartilage gets its nutrition from the perichondrium by the simple diffusion method. So nutrition is taken from the perichondrium. Perichondrium means the area that surrounds the cartilage, that is known as the perichondrium. And since this is avascular, what is the clinical importance of this avascularity? So if there is a stripping of the perichondrium, stripping means separation of the perichondrium from the cartilage. And when does the separation of perichondrium occurs? So usually the separation of the perichondrium occurs due to trauma of the pinna. And whenever there is a trauma, hematoma occurs, and this hematoma leads to the cutoff of the nutritional supply to the pinna. And due to the deprivation of the nutrition, the cartilage undergoes the necrosis, and later on there is a morphological changes, morphological deformity in the pinna, and that deformity is known as boxer's ear or cauliflower ear. So applied anatomy of the pinna. Why this pinna is very important for medical person? So Simba concha, I have told you earlier, Simba concha is the important landmark for the mastoid antrum. So mastoid antrum is just below the Simba concha. Another important landmark for the mastoid antrum you should remember is McEwen's triangle or suprameatal triangle. So this is a fancy name. You should remember this name. So McEwen's triangle or suprameatal triangle is just above the external auditory meatus opening. So this is situated just above the opening of the external auditory meatus, and below this McEwen's triangle or suprameatal triangle, 1 centimeter, when we go 1 centimeter deep to this triangle, there is a mastoid antrum. So above there is a Simba concha, in between McEwen's triangle, and deep to the McEwen's triangle there is a mastoid antrum. Another important landmark is the incisura terminalis. So this is the area between the cross of the helix and the tragus. This is devoid of the cartilage. There is also absence of the cartilage, and at this level, when there is a surgical procedure needed for the internal parts of the ear, like external auditory meatus or tympanic membrane, any surgical procedure that involves the external auditory meatus or tympanic membrane, the site of incision is the incisura terminalis. So another important thing about the pinna is its nerve supply. So in nerve supply, usually in the competitive examination, two questions are frequently asked. One question is, which nerve supplies the major portion of the pinna? So greater auricular nerve is the nerve that supplies the major portion of the pinna. You can see this diagram. This violet color or say brinjal colored portion is supplied by the greater auricular nerve, and this is the major portion of the pinna that is supplied by the greater auricular nerve. And this nerve arises from the cervical plexus, from cervical plexus 2 and 3. Similarly, in the medial part, this nerve is supplied from the third division, that is mandibular division of the trigeminal nerve. A small portion of the pinna is supplied by the cranial nerve number 7, that is facial nerve, and cranial nerve number 10, that is vagus nerve. And the branch that is supplied, the branch arising from the vagus nerve that supplies the pinna is known as Arnold nerve. So this is a fancy name for the branch that supplies the pinna from the vagus nerve. So Arnold nerve is the branch of auricular branch of the vagus nerve. So this is also one important point for the examination. You should remember this. Okay, let's start about the external auditory canal, which is also known as the external acoustic meatus. So the length of the external auditory canal is around 24 to 25 millimeter, that is 2.4 to 2.5 centimeter in length, and it is divided into two parts. lateral or outer part, which is also known as the cartilaginous part, medial or inner part, which is also known as the bony part or osseous part. So medially it is larger, longer in size, and laterally it is shorter in size. So cartilaginous part covers around 1/3 of the portion of the external auditory canal, and the bony part covers the 2/3 portion of the external auditory canal. The shape of the external auditory canal is S-shaped. This is the reason we have to pull the ear pinna upward to visualize the tympanic membrane, because the shape of the external auditory canal is S-shaped, and we cannot see the tympanic membrane directly if we don't pull the pinna upward. So starting about the cartilaginous part has a important fissures. So that fissure is known as fissures of Santorini, through which the parotid or superficial mastoid infection can appear in the canal. So sometimes the infection of parotid or infection of the superficial mastoid can appear into the external auditory meatus in the cartilaginous part of the external auditory meatus through one fissure. That fissure is known as the fissure of Santorini, or vice versa. That means the infection of the external auditory canal may enters into the parotid or superficial mastoid infection through this fissure. So this fissure is one of the important point for the examination. So the cartilaginous part is covered with a skin that is thick and has a ceruminous gland. So what are the ceruminous glands? Ceruminous glands are the modified sweat glands. These are the modified apocrine sweat glands. The skin also consists of the pilosebaceous gland and hair follicles. This ceruminous and pilosebaceous gland secretes the wax. So what is wax? Wax is the mixture of the cerumen, sebum. Sebum is produced by the pilosebaceous gland, and the de-squamated cells that is de-squamated from the lining epithelium of the skin. So these all things combine to form a wax. Since hair is confined to the cartilaginous part only, so hair is confined only to the cartilaginous part. Hair is not present in the bony part of the external auditory meatus. So since hair is confined to the cartilaginous part, furuncles or folliculitis are only seen in the cartilaginous part of the external auditory meatus. Folliculitis or furuncle is not seen in the bony part or osseous part of the external auditory meatus. So here in this diagram, you can see the fissures of Santorini. Fissures are the gap between the cartilage that is present inside the cartilaginous part of the external auditory meatus, and these cartilages are continuous with the cartilage of the pinna. So we have studied earlier that the cartilage of the pinna is continuous with the external auditory meatus. So here is the diagram showing that this cartilage is continuous with the elastic cartilage of the pinna. So let's start with another important part of the external auditory meatus, that is the bony part. So this bony part covers around 2/3 portion of the external auditory meatus. So a skin lining the bony part is thin. So in comparison with the cartilaginous part of the external auditory meatus, the skin covering the bony part is thin and is devoid of hair follicles and ceruminous gland. So there is no ceruminous gland in the bony part of the external auditory meatus. So 5 millimeter lateral to the tympanic membrane, bony meatus is narrow and called isthmus. So just beneath the 5 millimeter lateral to the tympanic membrane, this bony meatus is narrower, and that narrow part is known as isthmus. So why is this isthmus very, very important for the medical point of view? So since the foreign bodies get lodged in it, this area, so in the isthmus, any foreign body that is entering into the ear lodges at the level of the isthmus, and it is very difficult to remove when the foreign body is lodged at the level of isthmus. Beyond the narrow isthmus lies a dilatation. So behind this isthmus there is a wide area, and this wide area is known as anterior meatal recess, where the discharge from the middle ear gets collected. So if there is the infection of the middle ear like otitis media, the discharges from this middle ear gets lodged at the anterior meatal recess. And in the diagram here is one important foramen. That foramen is known as foramen of Husky. So what is the foramen of Husky? It is a deficiency present in the anterior-inferior part of bony part of the canal in the children up to 4 years of age, permitting infection to and from the temporomandibular joint. So this
foramen is important up to the edge of the fork, because the infection from the temporomandibular joint may enter into the ear through this foramen, or the infection from the ear may enter into the temporomandibular joint through this foramen. So this foramen has a connection between the ear and the temporomandibular joint. So another clinical important sign is seen in the external auditory meatus. So that sign is known as Hitzelberger sign. So what is Hitzelberger sign? This sign may be asked in the examination. So the posterior wall of the external auditory meatus is supplied by the facial nerve, and whenever there is a facial paralysis, there is the hypoesthesia of the posterior meatal wall, and that sign is known as Hitzelberger sign. So this is one of the important point for the examination. So the last part of the external ear is tympanic membrane, and tympanic membrane is 9 to 10 millimeter tall, 8 to 9 millimeter wide, and 0.1 millimeter thick. So imagine that 0.1 millimeter thickness. So how much thick is the tympanic membrane? It is very thin layer, very thin structure that is present in the ear, and it is positioned at the angle of 55 degree to the floor. So it is inclined in position. This is not placed straight. This is placed in the certain inclination at the degree of 55 degree. It is shiny and pearly gray in color. So normal tympanic membrane is mobile, with maximum mobility being in the peripheral part. So peripheral part of the tympanic membrane is more mobile than the central part of the tympanic membrane. So tympanic membrane is divided into two parts, pars tensa and pars flaccida. So pars flaccida is also known as the sharpness membrane. So this is also one important point for the examination. Pars flaccida is also known as sharpness membrane. So what are the important points regarding the pars tensa? Pars tensa forms the major portion of the tympanic membrane. The major part of the tympanic membrane is formed by the pars tensa. Peripheral parts become thick to form a fibrocartilaginous ring called annulus tympanicus. So in the diagram, you can see that the peripheral part of the tympanic membrane, pars tensa, has become thick to form a fibrocartilaginous structure to fit in the tympanic sulcus. Tympanic sulcus is the groove where the tympanic membrane is situated inside the bone. So this peripheral part of the tympanic membrane gets thick, and this structure is known as tympanic annulus, and this tympanic annulus fits into the tympanic sulcus. Annulus tympanicus is absent above, and it forms a notch called notch of Rabinowitz. So in the diagram, you can see here in the upper part of the tympanic membrane, there is no tympanic annulus. There is a notch-like structure, and this notch is known as notch of Rabinowitz. And this area is devoid of this fibrocartilaginous tympanic annulus. Central part is tented inward at level of handle of malleolus called ombo. So central part is tented inward because of the handle of the malleolus, and that tenting is known as ombo. Cone of light is seen radiating in the anterior-inferior quadrant. So this is another important point for the examination. So which quadrant, cone of light is seen in which quadrant is frequently asked in the examination. So cone of light is seen in the anterior-inferior quadrant of the tympanic membrane. Another part of tympanic membrane is pars flaccida, which is also known as the sharpness membrane. Sharpness membrane lies above the lateral process of malleolus and between the nodes of Rabinowitz, above and anterior and posterior malleolar fold below. It is mobile and flaccid than pars tensa. It is freely mobile and it is more flaccid than the pars tensa. This is because of this reason, cholesteatoma is formed by the pars flaccida, because when there is a negative pressure in the middle layer due to blockage of the eustachian tube, this leads to the formation of the retraction pocket, and this retraction pocket later on develops into the cholesteatoma. There are three layers of the tympanic membrane. Outer layer is the epithelial layer, middle layer is the fibrous layer, and mucosa layer is the inner layer of the tympanic membrane, and this mucosal layer is continuous with the middle ear mucosa. And few another important points of the tympanic membrane are When a tympanic membrane perforation heals spontaneously, it heals into two layers only. So there are three layers of the tympanic membrane, but when there is a perforation and after perforation, healing starts spontaneously. And during the healing, the middle layer, fibrous layer, is not developed so quickly, but the mucosal layer and outer epithelial layer develops quickly. This, because of this reason, the fibrous layer does not develop and only two layers get developed, and after the healing there is only two layer present in the tympanic membrane. Nerve supply of the tympanic membrane is also important. Tympanic membrane is supplied by three nerves. The auricular division of the mandibular branch, that is third division of the trigeminal nerve. It is also supplied by the auricular branch of the vagus nerve, that is known as Arnold nerve or Alderman nerve. It is also supplied by the cranial nerve number 9, that is glossopharyngeal nerve, and the auricular branch of the glossopharyngeal nerve is known as Jacobson's nerve. So this is all about the external ear anatomy. Medial ear anatomy will be discussed in the next lecture. Thank you.